Today we will discuss about various causes of hyperkalemia and approach to hyperkalemia. First, we should rule out pseudo-hyperkalemia. Pseudo-hyperkalemia means if there is in vitro hemolysis, there will be increased potassium concentration. Whenever there is cellular efflux of potassium from cells to outside, there can be hyperkalemia. So, cellular efflux is one cause, and in vitro hemolysis. If there is leukocytosis or thrombocytosis or erythrocytosis in the sample, if the cell count is more, WBC more than 50,000 or platelets more than 10 lakhs, in those situations, if there is clot inside and there will be potassium released from those cells. So, whenever there is leukocytosis or thrombocytosis or erythrocytosis, so in vitro hemolysis, if there is cellular efflux from potassium, in those conditions there will be pseudo hyperkalemia or clenching of the fist during venipuncture or immediately after exercise if you take blood sample. In those situations there can be mild hyperkalemia. So we should rule out those pseudo hyperkalemia causes. There are some hereditary causes also. There is red cell membrane defect. There is mainly anion exchanger 1. There is mutation in the anion exchanger 1 protein. There will be efflux of potassium from cells to outside. That gives mild hyperkalemia. So after pseudo hyperkalemia, most important cause is redistribution of potassium from cell to outside. So important cause is acidosis. What happens in acidosis? Why there will be hyperkalemia? There will be acidosis means increased hydrogen ions. There will be shift of hydrogen ions into the cells. H plus HK ATPase enzyme. Hydrogen ions they shift inside the cells. Potassium it will come out of the cell. So with HK ATPase enzyme in acidosis there will be hyperkalemia and hyperosmolar conditions. If you give IV mannitol or hypertonic saline or hypertonic glucose, immunoglobulins, radio contrast dyes, in all those conditions there are hyperosmolar states. The mechanism for hyperkalemia is solvent drag effect. If there is a hyperosmolar solution, because of solvent drag effect, the potassium will come out of the cell. Drugs inhibiting sodium potassium ATPase like beta blockers, digoxin. How sodium potassium ATPase inhibition causes hyperkalemia? What is sodium potassium ATPase action? During depolarization there will be more sodium entry into the cell. So after depolarization, with sodium potassium ATPase activity, sodium come out of the cell. 3 sodium, 2 potassium will move inside the cell. That is sodium potassium ATPase enzyme activity. 3 sodium outside, 2 potassium inside. If sodium potassium ATPase is inhibited, then there will be more potassium outside the cell. Most important cause is beta blocker, non-cardioselective beta blockers. Then glycosides like digoxin. Glycosides, other examples are foxglove in plants, yellow oleander, foxgloves, they are all glycosides. In the animals, toad skins, bufadienolide, it contains glycosides. So digoxin, yellow oleander, foxglove and toad skin. Those who eat toad skin, bufadienolide. In those conditions, there will be inhibition of sodium potassium ATPase. Even fluoride also. In fluoride intoxication, there will be inhibition of sodium potassium ATPase. And hyperkalemic periodic paralysis. Again, there will be redistribution of potassium in the cells. Potassium will move from cells to outside. That is hyperkalemic periodic paralysis. If there is intake of lysine, arginine or epsilon aminocaproic acid, they are all cationic amino acids. Lysine, arginine are cationic amino acids. If there is accumulation of lysine, arginine, potassium will move out of the cells. Epsilon aminocaproic acid almost structurally similar to these cationic amino acids. Or succinylcholine can cause mild hyperkalemia. There will be 0.5 milliequivalents per liter increase in potassium levels. Here the cause is it acts on acetylcholine receptors, and again there will be inhibition of sodium potassium ATPase. Succinylcholine will cause only mild hyperkalemia. That too only for few minutes, 5 to 10 minutes only. That effect will be for 5 to 10 minutes. But in certain situations, the effect will be more and there can be serious complications. Like in patients with thermal injury, neuromuscular dermal trauma, and neuromuscular injury, mucositis or immobilization states. In those conditions, there will be denervation hypersensitivity, more acetylcholine receptors on the cell, there will be more succinylcholine action. In those situations, there will be significant hyperkalemia. Except in those situations, succinate choline causes only mild hyperkalemia, that too it lasts for only a few minutes. So dermal trauma, neuromuscular injury, mucositis, and prolonged immobilization, disuse atrophy. And other causes for redistribution are rhabdomyolysis, tumor lysis syndromes. There will be release of potassium, phosphate. Important causes are for the redistribution, acidosis, that's the most important cause. Then hyperosmolar states, solvent drag effect, inhibition of sodium potassium ATPase activity by beta blockers, redoxin fluoride. Then hyperkalemic periodic paralysis. Then cationic amino acids, lysine, arginine, or epsilon aminocaproic acid. Then succinyl choline. Then tumor lysis, rhabdomyolysis state. So next important cause is decreased renal secretion. The decreased renal secretion that causes hyperkalemia. There are drugs causing hyperkalemia. If renin-angiotensin system is inhibited, that will cause hyperkalemia. Means ACE inhibitors, angiotensin converting enzyme inhibitors, the renin inhibitors, and angiotensin receptor blockers. Renin inhibitors like L-screen, ACE inhibitors, angiotensin receptor blockers, or mineralocorticoid receptors, aldosterone blockers like spironolactone, eplerenone, drospirenone. Then enact channel inhibitors, amiloride, trimethoprim, then trimethoprim, pentamidine, nafamostat, it is a protease inhibitor. So ACE inhibitors, renin inhibitors, angiotensin receptor blockers, aldosterone blockers, enact channel blockers. All these conditions, there will be hyperkalemia. So from juxtaglomerular cells, renin is released. There is hypovolemia. From juxtaglomerular cells, renin is released. That renin causes conversion of angiotensinogen to angiotensin 1. Angiotensinogen is produced in liver. From angiotensin 1 to angiotensin 2. That is by angiotensin converting enzyme. That is produced in lungs. Angiotensin 2 acts on adrenal cortex, glomerulosa, acts on glomerulosa, releases aldosterone. Aldosterone acts on principal cells of the tubule, epithelial cells of the principal epithelial cells of the tubule. This is lumen, tubular cell. Aldosterone acts on the basolateral membrane, causes 3 sodium out and 2 potassium in. There are several actions. It acts on sodium potassium ATPase, 3 sodium move out of the cell. So there will be lumen negativity. Cell potential, there will be negative potential. Almost it goes up to minus 60, 70 millivolts. Then here enact channels. Enact channels means endothelial, epithelial sodium channels. Enact channels are activated. More sodium entry into the cell. Because of lumen negativity, there will be more sodium entry from lumen. If there is more sodium entry, then here lumen, there will be lumen negativity. More negative potential is created in the lumen. That causes potassium secretion, potassium and hydrogen secretion. So aldosterone action means mainly sodium retention and potassium hydrogen secretion. But how sodium retention is started? Because of sodium potassium ATPase activity by the aldosterone. So lumen negativity is created. That initiates sodium entry inside the cell. There will be lumen negativity. That initiates potassium and hydrogen secretion. Potassium and hydrogen secretion means hypokalemia. So aldosterone activity, hyperaldosteronism causes hypokalemia. But if there is inhibition of RAS, then there will be hyperkalemia. So inhibition can be from starting from renin. There can be renin inhibitors, angiotensin converting enzyme inhibitors, angiotensin blockers, receptor blockers, or aldosterone antagonists, or enact channel inhibitors. They are drugs causing hyperkalemia. And for potassium secretion, if there is increased delivery of sodium to the distal tubule, whenever there is increased flow or solute delivery to the distal tubule, there will be more potassium secretion. If there is more flow or solute delivery, sodium delivery to the distal tubule, then there will be sodium retention. There will be more sodium absorption in the epithelial cells. There is more sodium entry, there will be more potassium hydrogen secretion. So whenever there is increased flow, distal flow, or increased solute delivery to the distal tubule, there will be more sodium retention and there will be more potassium secretion. That causes hypokalemia. But whenever there is decreased delivery, of sodium to distal tubule, whenever flow is less, tubular flow is less, that causes diminished secretion of potassium to lumen that causes hyperkalemia. So second mechanism is decreased distal delivery of solutes, sodium, and decreased tubular flow. For example, in congestive cardiac failure or in hypovolemic states, tubular flow is low, there will be decreased potassium secretion. Whenever there is hypovolemia, there will be tendency for hyperkalemia, mild hyperkalemia, because there is decreased tubular flow. Or whenever there is decreased sodium entry into the distal tubule, then there will be decreased secretion of potassium that causes hyperkalemia. That is second mechanism. The drugs causing hyperkalemia and decreased distal flow or decreased distal sodium delivery. Third important cause is hyporenemia, hypoaldosteronism. Hyporenemic, hypoaldosteronism conditions. Low renin, low aldosterone conditions is important. Hyporenemic, hypoaldosteronism. Those states are very important. In several conditions, both renin and aldosterone levels are low. Mainly tubulointerstitial diseases. Tubulointerstitial diseases. Like there are many conditions like SLE. SLE can cause tubulointerstitial disease, amyloidosis, sickle cell anemia, even obstructive uropathy can cause, in post-ATN states. In all those conditions where there is involvement of tubule and interstitium, if juxtaglomerular operators are involved, if the distal tubule is involved, there will be decreased renin secretion, then there will be decreased aldosterone secretion. So if tubules and interstitium are involved, if there is significant damage to the nephrons, whenever there is significant damage to the nephrons, then renin production will be low, then aldosterone release will be low. They are all hyporenemic, hypoaldosteronism states. So one is tubulointerstitial disease. What are the drugs causing tubulointerstitial disease? NSAIDs can cause, even beta blockers, COX-2 inhibitors, cyclosporin, tacrolimus. They all can cause tubulointerstitial disease, interstitial nephritis. Even diabetes is a classical example. Diabetic nephropathy state. Beta blockers can cause interstitial nephritis. Cyclosporin, tacrolimus. So diabetes and diabetic nephropathy. One is tubulointerstitial disease. There are many systemic conditions. Two, diabetic nephropathy. Three, drugs. Even elderly people with chronic kidney disease, they have tubule and interstitial involvement. And pseudo-hypoaldosteronism. In pseudo-hypoaldosteronism type 2, there will be genetic mutations, and that can cause decreased aldosterone and renin level situation. The genetic mutations are mainly in the WNK1,4 kinases, serine, threonine, WNK1 and 4 kinases, and Kelch-like 3 and Kalin 3, these are involved, and they are mainly part of E3 ubiquitin ligase complex. If these are involved, that causes hypoaldosteronism type 2. They are familial causes, hypoaldosteronism. Even in CKD or acute kidney injury or in end-stage renal disease, in all these conditions, there can be hyperkalemia. So all kidney states, acute kidney injury or CKD in end-stage renal disease patients. And another mechanism is resistance to mineralocorticoid. Whenever there is resistance to mineralocorticoid, in all tubulointerstitial disease, there will be resistance to mineralocorticoid. If familial causes, the hypoaldosteronism type 1, there will be resistance in the NAC channels that can cause hyperkalemia. And adrenal gland involvement, there is direct adrenal gland involvement. Aldosterone deficiency will cause hyperkalemia. So direct adrenal gland involvement. There are autoimmune conditions. There are endocrinal conditions, autoimmune conditions like adrenal hypoplasia, or in the part of multiple endocrinopathies, Mann syndromes, there will be adrenal gland involvement. And infiltration, amyloidosis, in malignancy, metastasis, there is infiltration of adrenal gland, there will be adrenal insufficiency. Or drugs can cause decreased production of aldosterone. Like heparin can cause, even beta blockers, cyclosporin, the ketoconazole, they all decrease aldosterone production. Whenever there is decreased steroid synthesis, ketoconazole inhibits steroid synthesis. That can cause decreased aldosterone production. Or there are hereditary conditions involving adrenal gland, causing adrenal insufficiency and hyperkalemia. Congenital lipoid adrenal hyperplasia or hypoplasia adrenal congenital conditions, adrenal synthase deficiency. In all those hereditary conditions, there will be adrenal insufficiency or adrenal gland hemorrhage or adrenal gland infarction. in antiphospholipid syndromes. Wherever there is adrenal gland involvement with decreased synthesis of aldosterone, that can cause hyperkalemia. So can you list out all the causes coming from pseudo hyperkalemia? First to rule out pseudo hyperkalemia. So look for causes of conditions where there is cellular reflux, in vitro ex vivo hemolysis. So whenever there is leukocytosis, thrombocytosis, erythrocytosis, pseudo hyperkalemia can occur. Or whenever there is red cell membrane hereditary defects, AE1 defects. So rule out pseudo hyperkalemia. Then check whether there is increased intake of potassium. Intake of potassium means potassium rich foods. Whether there is any increased intake in the presence of diabetic nephropathy or in CKD, even increased intake can cause hyperkalemia. So potassium rich foods or potassium salts. Patient is taking potassium salts, or there is administration of potassium chloride, IV potassium chloride, or antibiotics with potassium penicillins. So exogenous administration or increased intake. So in the approach, severe hyperkalemia means if potassium is more than 6.5, that is severe hyperkalemia. Or if patient has ECG changes, hyperkalemia related ECG changes, cardiac arrhythmias, or if potassium level is more than 6.5. So first, if there is hyperkalemia, if it is more than 6.5, if there are ECG changes, clinically unstable, then directly manage potassium. Directly manage potassium. But if patient is stable, if less than 6.5, or if there are no ECG changes, even if it is 6.5, there are no ECG changes, then we should first rule out pseudo hyperkalemia, then look for all transcellular shift conditions, redistribution of potassium, any hyperosmolar states, IV mannitol, hypertonic saline, hypertonic glucose, or dyes, contrast dyes, or immunoglobulin, high immunoglobulin levels, hyperosmolar states we should rule out. Then decreased sodium potassium ATP states. The patient is on beta blockers, digoxin, or if there is fluoride intoxication. Then check whether there is any thyrotoxic or periodic paralysis condition. All causes of transcellular shift, lysine arginine infusion, or succinylcholine, or tumor lysis syndrome, rhabdomyolysis. So look for those causes. So rule out transcellular shift conditions, redistribution of potassium causes. Then check urine potassium. First step is check urine potassium. If urine potassium, there will be decreased secretion of potassium. The main mechanism for hyperkalemia is decreased secretion of potassium. If urine potassium is less than 40 millimoles, means decreased secretion is the main mechanism. For that, first check urine sodium also. If there is less solute or decreased flow into the distal tubule, hyperkalemia can occur. So check urine sodium. If urine sodium is low, if urine sodium is less than 25 milligrams per liter, then decreased sodium entry into the distal tubule is the cause for hyperkalemia. So first we should rule out that. For that you check urine sodium. If urine sodium is normal, then we have to evaluate all other causes. So we'll check transtubular potassium gradient, TTKG. Normally in hyperkalemia, TTKG will be more than 8. In hypokalemia, TTKG will be less than 3. The TTKG formula is urine potassium into serum osmolality divided by serum potassium into urine osmolality. So in hyperkalemia, we expect more than 8. If it is more than 8, it means distal tubular flow is less. If distal tubular flow is low means either low extracellular fluid volume, hypovolemic states, or if GFR is less than 20 ml per minute, tubular flow will be low, and that is the cause for hyperkalemia. If TTKG is less than 5, it means GFR is more than 20 ml per minute, then we should give 9 fludrohydrocortisone. We should give injection 9 fludrohydrocortisone. This is one flow chart to assess various causes of hypokalemia. So various causes are, we discussed about pseudo hyperkalemia and redistribution of cells. Then drugs where there is decreased potassium secretion, mainly drugs causing hyperkalemia. Renin inhibitors, AC inhibitors, AC enzyme inhibitors, angiotensin receptor blockers, and aldosterone antagonists, NAC channel inhibitors. These are drugs that cause hyperkalemia. Then second, decreased distal tubular flow. Decreased solute delivery to distal tubule. Congestive cardiac failure and hypovolemia. Then hyporenemic hypoaldosteronism conditions like tubulointerstitial diseases like SLE, sickle cell anemia, amyloidosis, obstructive uropathy, post-ATN situations, diabetes, diabetic nephropathy, or drugs like NSAIDs, COX-2 inhibitors, beta blockers, cyclosporin, tacrolimus, elderly people, or with kidney disease, or with familial causes of hypoaldosteronism. In type 2, there will be genetic mutations in the WNK1, 4 serine threonine kinases, Kelch-like 3 choline genes, ubiquitin ligase complex gene, these are involved. Then kidney diseases like in CKD or AKI or ESRD, or in conditions where there is resistance to the mineralocorticoid, aldosterone resistance. Aldosterone resistance will be there in all tubular interstitial diseases, or in familial causes, type 1, there will be resistance in the ENaC channels. Finally, adrenal gland insufficiency, adrenal gland involvement in adrenal hypoplasia or polyglandular endocrinopathies. Then drugs inhibiting aldosterone secretion like heparin, even cyclosporin, ketoconazole, AC inhibitors, the drugs. And infiltration like amyloidosis, metastasis, malignancy. Again, there are hereditary causes, congenital lipoid adrenal hyperplasia or adrenal hypoplasia, adrenal synthase deficiency, or adrenal gland hemorrhage or infarction in antiphospholipid syndrome, or with infections affecting the adrenal gland. Previously, in olden days, tuberculosis is the important cause for adrenal insufficiency. Next, nowadays, HIV was an important cause for adrenal gland involvement. So, HIV, tuberculosis, are disseminated fungal infections. There are many infectious conditions with adrenal gland involvement. So, these are the causes of hyperkalemia, and the flow chart to hyperkalemia is, if there are clinical manifestations, if there are significant ECG changes more than 6.5, directly treat hyperkalemia. Then check if patient is stable, look for pseudo hyperkalemia causes, transcellular shift conditions. Then check urine potassium. If urine potassium is less than 40 millimoles, then check urine sodium. If urine sodium is low, it means the main mechanism is low flow, low solute entry into distal tubule. Sodium intake is low. If urine sodium is normal, then we should check TTKG, transtubular potassium gradient. Depending on that, if GFR is less than 20 ml per minute, decreased distal tubular flow conditions, low aldosterone conditions, primary adrenal gland involvement, or lower renin conditions, or with tubular resistance conditions. How do you manage hyperkalemia? There are three main goals. Hypokalemia can be tolerated, but hyperkalemia more than 6.5 is an emergency. With hyperkalemia, initially there will be T wave change, peak T waves. With 5.5 to 6.5, there will be T wave changes, P, QRS, T, again P, QRS, T. Okay? Always start with T, the peak T wave. From 5.5 to 6.5, peak T wave. After T wave, the P wave. So diminution of P wave and prolongation of PR, absent P wave. 6.5 to 7.5. Then QRS changes. From above 7.5 will be QRS prolongation. First T wave, peak T wave, 5.5 to 6.5. Then P involvement and PR prolongation. Then QRS changes. And finally, there will be sine wave pattern, serious cardiac arrhythmias, sine wave pattern and cardiac arrest. So how do you manage? So three goals. One is stabilization. Membrane stabilization is most important. That is emergency. For membrane stabilization, we give calcium gluconate. Calcium chloride is preferable, calcium gluconate is preferable. 10% calcium chloride, 10% calcium gluconate. In calcium chloride concentration is more, or in calcium gluconate chloride concentration is more? The calcium concentration. Elemental calcium is more in calcium chloride or calcium gluconate. Elemental calcium 3 times more in calcium chloride injection, 270 milligrams per ml. In calcium gluconate, 90 milligrams per ml. So in calcium chloride, 10% calcium chloride, elemental calcium is more, 270 milligrams per ml. Whereas in calcium gluconate, only 90 milligrams per ml. But in calcium chloride, the disadvantage is very hyperosmolar state. Osmolality is high, calcium chloride, almost 2000 milliosmoles per kg, high osmolality. So high osmolality, so highly irritable and highly concentrated solutions. So we will avoid those solutions because of high osmolality and is very irritable. So we prefer central veins and we prefer calcium gluconate. So 10% calcium gluconate, 10 ml or a period of 3 minutes. We can give in 3 to 5 minutes. But we should not give calcium gluconate if there is digitalis toxicity. If digitalis toxicity is causing hyperkalemia, then we should not. But if patient is on digoxin, if we have to give calcium gluconate, we should give the 10% calcium gluconate in 100 ml of saline for a period of 30 minutes. If digitalis toxicity is the cause for hyperkalemia, we should not give a calcium gluconate. So that is one. For membrane stabilization is most important. 10% calcium gluconate, 10 ml. The maximum action will occur in 30 to 60 minutes time. The first goal, membrane stabilization. Second goal is transcellular shift with insulin dextrose. How much insulin will give? Or bolus we can give. We can give insulin bolus. Then dextrose infusion. 50% dextrose in 50 ml saline. That is around 25 grams of glucose. So we'll give bolus insulin followed by 50 ml 50% dextrose, then followed by dextrose infusion. Again, maximum action will be around 30 to 60 minutes. That's second goal, transcellular shift. Third goal is elimination of potassium with resins. Which resin? K-oxalate. What is the K-oxalate chemical compound? Sodium cation exchange resin, sodium polystyrene sulfonate. Why it is called cation exchange resin? Potassium will be eliminated. Potassium will be eliminated through gut in exchange of sodium. So sodium polystyrene sulfate. Here the cation exchange is between sodium and potassium. So there will be potassium secretion in the gut and there will be sodium entry into the blood. One caution is we should not give cation exchange resins if there is hypernatremia or if there is increased extracellular fluid volume, hypernatremia states, or if ECF is high. Additional resins apart from cation exchange resin, there are calcium exchange resins. In high extracellular fluid volume states, then we can give calcium exchange resins. There will be exchange of calcium and potassium. And third most important is, with less side effects, is sodium zirconium cyclosilicate. That is the better one. The important side effect with cation exchange resin, K-oxalate, is it is diluted with sorbitol, 20% sorbitol or 33% sorbitol. Usually we'll dilute in 20% sorbitol. We'll give only with sorbitol. Why we will give only with sorbitol? To prevent concretions. Otherwise concretions will form. So orally or through enema. Orally or with enema we give K-oxalate. Most important side effect is bowel necrosis. Bowel necrosis can occur with either K-oxalate alone or with K-oxalate with sorbitol. In both conditions, bowel necrosis will be an important side effect. You should look for whenever there is severe pain or bowel necrosis signs or symptoms. So bowel necrosis is more common if we give K-oxalate through enema, if intestinal motility is less, or if patient is on opioid analgesics, intestinal motility will be less. In those conditions, with K-oxalate, chances for bowel necrosis are more. The last option is hemodialysis. Hemodialysis is better than peritoneal dialysis. Again, potassium 1 milliequivalent per liter decrease will occur within 1 hour time. 2 milliequivalents per liter decrease will occur in 3 hours time with hemodialysis. Again, that depends on flow and dialysis, which dialysate you are using, and concentration gradient between dialysate and serum and dialysis membrane. These factors they influence. So last option is hemodialysis. So membrane stabilization by IV calcium gluconate, then transcellular shift, insulin dextrose infusion. And other option is beta agonists will give albuterol nebulization. Again, that will cause transcellular shift. Then sodium bicarbonate also, depending on the condition. If pH is less than 7.0, then we can give sodium bicarb. But the disadvantage is if we give sodium bicarb along with calcium gluconate, calcium bicarbonate complexes will form. Should not give along with calcium gluconate. And if we give soda bicarb only for few hours, it is not much effective. Even with beta agonists also, if we have to give 4 times the therapeutic dose, we have to give high doses of albuterol. Then only there will be change of around 1 to 1.5 milliequivalents. We have to give in high doses, 4 times more than regular therapeutic doses. Again, important side effects for beta agonists are tachycardia, even hyperglycemia can occur. Then cation exchange resins, hemodialysis.